Again, yet another new session of Polaris Talks. I welcome each one of you who has gathered here. A very warm good evening as well. So today we are here for the continuation of our general anatomy of skin and fascia, where we'll be discussing about fascia in detail. So for that, we have our dearest Chief Academic Officer, Dr. Sanjit Bajpayee with us today. Hi, sir. Good evening.
Good evening, Aishwarya.
Hope things are fine there.
Yes, everything is fine.
Yeah, so I think we have a small news for you. Dr. Ryan Fernandez, Medical Director at Dr.Polaris, usually used to be there with us for all our Polaris talks. So unfortunately, sir has got an emergency call today. So he will not be able to join us. So I think, sir, we can have the session today and we can have the Q&A on the next session, maybe?
We'll have it. No issues.
No issues. Okay,
Yeah.
then. Okay, then.
Yeah.
All right. So over to you. I'm not wasting much of your time, sir. Over to the expert for the session. Thank you.
Yeah. So thank you so much, Aishwarya. I hope everyone is doing fine and the dearest students who have joined today. So what we are trying to do, we are trying to create a kind of, an environment where you start loving anatomy. And my idea of reading and learning anatomy has since forever been through diagrams. So what we learn each and every day in general anatomy is not going to be theoretical. It is going to be more diagrammatic so that you start thinking more. You start thinking more as well as relating more in real life scenarios. So what I'm going to discuss today is somewhat a continuation of what I have discussed in the previous segment. So I've already completed the epidermis and the dermis. So the skin as per se has been covered. Now we are digging into deeper structures. Okay. One of the questions which will be asked to you in the same way as I have written the heading. Define the anatomy of fascia as well as give its modification. So this is going to be your long answers when you are appearing in your first year exams and one of the most hit topics asked by people, not even in your just theory exams, but also in your vivas. So we are going to see a lot of things in this particular topic. Right. Now, let me first take you through what exactly we mean by fascia. Now, when we are taking the term fascia, wherever it is, whatever it is, fascia is a generic term. That means that it is a sheet. Okay. Now, anatomically, a sheet is called as a sheath. So always remember these two terms. Whenever we are talking about sheath or sheet, we are always talking about facial layers. Okay. So sometime you might be thinking about the neck. There, the deep fascia might be just called as an investing sheath. So don't get confused. Whenever I'm using the term sheath, it is always about the fascia. Okay. Now, what exactly is this fascia doing? This fascia is a dissectable mass because we can dissect it out, and it basically attaches or it wraps around and it separates one structure from another structure. So we know that above structure is the skin, which is again having epidermis and dermis. Below is our muscle layer and organs. So the intermediate layer lying in between the deeper structures and the superficial structures, the skin, is a sheet that is called as fascia. Right? So these are the two things that you should know. Now, whenever we are thinking about fascia, there are certain functions of a fascia that should come in our mind. Now, I'm going to tell you a mnemonic. This is a trick. And once we end this whole scenario of reading fascia, you will understand how this mnemonic will come into play and how you can use it in everyday life. Okay. So remember the mnemonic trap. That means wherever your fascia will come, superficial fascia, deep fascia, whatever fascia is there, they are primarily going to have four major functions. Okay. And the mnemonic is trap. First is T. T means what? Transmission. That means the fascia itself acts as a conduit for transmitting multiple things through it. That means multiple things like vessels, it can be nerves, there can be lymphatics, there can be any kind of lymph nodes. Everything is residing through the fascia. They are all moving through the fascia, right? So that is why it is transmitting vital structures. Okay, that is the first T. Now let me come to the second one. Second one is R. Wherever there is fascia, it is attaching one structure above and one structure below. So it is preventing the friction between two structures. That is the above structure and the below structure. And I'm going to show you how it prevents the friction. Okay. So that is reduction of friction. Now comes A. A means attachment. Fascia gives a lot of attachment to muscles. Okay, so there are various muscles which attach, there are various muscles which originate, they are all finally from the fascia, right? So it is giving attachment to different structures, and we are going to see that. Okay, and the last is protection. So what exactly it's protecting? It's protecting the underlying viscera. Viscera means organs. So it's underlying organs or underlying muscle, underlying joints. Everything is being protected by this sheet or sheath that is present above, right? So remember this mnemonic trap. It is going to help you a lot by the time we end today. Okay. Now we come to what are the types of fascia. And this is general all over the body that I'm talking about. There are two types of fascia in our body. One is above, that is called as superficial fascia. Superficial means superiorly or above. One is deep to it. This is called as deep fascia. Okay, so I am going to take superficial fascia separately. Then I'm going to go into deep fascia. Then we'll see clinical scenarios as to what things can go wrong when these fascias are not working fine. Okay, fine. So first, let's dig into what exactly is superficial fascia. Now, don't get confused. People will confuse you with different terms. I have taken a little bit of this particular thing in the previous segment also, but I'm again going to repeat it. Superficial fascia, aka also called as tela subcutanea. Now, what do you mean by that? Subcutanea means below the cutaneous layer. That means below the skin, right? So superficial fascia can also be called as tela subcutanea. It is also called as hypodermis. It is also called as subcutaneous tissue. So whenever and wherever you are getting these terms, always think that they are all talking about superficial fascia. These all terms are synonymous. They are all the same, right? Okay. Now, once we are talking about superficial fascia, I have already covered that the topmost layer of the skin is called as the epidermis. Below that layer of the epidermis is something called as dermis, which dermis also is divided into two parts, that is papillary dermis above and reticular dermis below. These are the two parts of the dermis. Now, this dermis and epidermis forms a part of the skin, right? But what we are talking about below the skin. Now, below the skin is what? Below the skin is a layer that is called as hypo. Hypo means below the dermis. So hypodermis or subcutaneous tissue, or we call it the tela subcutanea or superficial fascia, it is all the same. Okay, so this particular layer that you are seeing is called as the superficial fascia, right? Now, this superficial fascia or the subcutaneous tissue, as you can see, is a lot yellow. Okay, so what we say that this contains a lot of fat cells, and because it contains a lot of fat cells, this is very loosely arranged. It is not very tight like deep fascia. This is very loosely arranged. So we call it is inside a loose connective tissue which is abundant in fat cells. Are you understanding it? Right? So this particular superficial layer or subcutaneous layer is abundant with fat cells. Now, what exactly you mean by that? Abundant with fat cells. So, as I already told you, it is a fibrous mesh which is filled with fat. Okay, and you already know that it is connecting one surface above, that is the superficial skin, and below, that is the deep fascia. So you know, just beneath the superficial fascia is deep fascia, that is below. Skin above, deep fascia below, in between that layer is called as superficial fascia, and it is containing a lot of fat cells. I'm going to show you the diagram of how exactly these fat cells look like. Okay, now I told you this particular layer contains, or this particular fascia has a lot of transmission. If you remember that T, right? It contains a lot of things inside. Now, the most abundant thing in the superficial fascia, as already told you, is fat. Fat is made up of fat cells. Fat cells are called as adipocytes. Okay, adipose means fat, cyte means a cell. Fat cell is called as an adipocyte, and I'm going to show you that. So it contains majorly this fat and areolar tissue. It also contains, I told you, it acts as a conduit for various structures to pass through. So it acts as a conduit for nerves, various vessels, as well as lymphatics. They all have to go through this particular fatty layer or this particular facial layer. That's called as the superficial fascia. Now comes an important gland. Now, this is a very important question for you. Name a gland inside the human body which is basically present in the superficial fascia. This gland, the mammary gland. Mammary gland is a modified sweat gland. This is the term that they have asked you a question. Name a gland which has a modified sweat gland. What is that? Mammary gland. Okay, it is an apocrine variety of a modified sweat gland. Now, what do you mean by all these terms? You have something called as sweat glands, right? They are secreting something. Now, these glands are modifications of sweat glands, and they are apocrine variety. Now, what do you mean by apocrine? Apocrine means that once they release their material, whatever they are releasing, a part of the cell will also come out. That's called as apocrine secretion. So always remember these two terminologies. Again and again, I'm going to repeat. Mammary glands are basically just modifications that are present itself in the superficial fascia. One, these are modified sweat glands and they are apocrine variety. Three things you need to remember when I'm talking about mammary glands. And I'm going to again and again repeat this once I come. They also have lymph nodes because there are lymphatics. Though they will definitely drain into something that's called as a lymph node. And they can also have a muscle. So I'll tell you what exactly are modifications of superficial fascia. So you'll understand what muscles are there in superficial fascia later on, right? Okay. Now you know what is the definition, what contents are there inside the superficial fascia. Now we move on to understanding these contents. So I already told you, if I ask you in one word, what is the most abundant thing in superficial fascia or tela subcutanea or hypodermis? What is that thing? Fat. Okay. So you must have seen this kind of a term in your textbooks. Okay. So anatomy has been a lot of Latin words. And my idea of reading anatomy is catch this Latin. Take these Latin words, turn them into normal words for your own sake, and then you will remember why they have been named like that. So I'll tell you how they have been named. So I told you that in your hypodermis or beneath the dermis or this superficial layer contains a lot of fat cells. And this fat cell, I already told you, this is called as an adipocyte. This adipocyte, how it is peculiarly an adipocyte is because it contains something called as a nucleus. Nucleus present in a fat cell is always present at the periphery. Now see, this is the periphery or the end of this fat cell. It is always present towards the periphery. And the major part inside is filled with a lipid droplet. So you see, this is the fat reservoir, which is the lipid droplet, and it has got this nucleus, which is what we call as eccentric. Eccentric means towards the periphery, right? ECC, not the exact eccentric. This is towards the periphery, right? So this nucleus is flat and it is towards the periphery and it is filled with drop in the center. This is a characteristic of fat cell. Now this layer, because it contains a lot of fat, it also is given the name as paniculus adiposus. Now, what do you mean by this term? Paniculus is a Latin word which literally means a sheet, and adiposus means fat. So a sheet of fat is basically hypodermis or paniculus adiposus or tela subcutanea or subcutaneous layer or anything below the dermis or a hypodermis. Are you understanding it? So that is why it is also named as paniculus adiposus, because it contains a lot of fat cells, right? So this is about general things. What exactly are the contents of this particular superficial layer? Now let me get you to clinical scenarios, okay? You must have seen people who are very athletic, right? And people have these kind of bodies, they have got abs. One type of category of people are these who are very, very fat, right? And sometimes you can even see that many of the bodies have these kind of dimples. They must have got these dimple in every area. Everything depends upon the thickness of this particular subcutaneous fat, which I've already told you. So the amount of thickness of this hypodermis, whenever we are eating a lot of food, our fat is getting stored, right? And the thickness of this hypodermis is getting increased. Now, because of the increase in this hypodermis, what are we having? We are having these kind of scenarios. Person is becoming so fat, right? So all the fat is getting stored here. Now, I'll tell you later on why this fat is getting stored here also. Similarly, if you see this athletic man, right? This person has got a lot of muscle mass. He's got abs. Why? Because the hypodermis is very thin. It's very, very thin. That is why the maximum musculature is shown up. Okay. And this kind of a thing where you have these kind of dimples that get formed, this is called as a cellulite. That means what? That fat gets deposited in the form of columns. So one column, another column, another column. This kind of a body is called as a cellulite body, right? So you might find these kind of scenarios in your everyday life. You might find a person who's very fat, and then you will finally realize that no, I shouldn't call a person, when you're an anatomist, you shouldn't call a person fat. or anything like that, you say, no, in your hypodermis, a collection of adipose tissue is much more than the normal. So I think you should lose on something, right? So this is how you have to incorporate these regular things in your regular scenarios. Okay, then you will remember anatomy more. Okay, now we move on to distribution of superficial fascia. Now, whenever I read superficial fascia, I remember this fat man, and I'll tell you why. Okay, so superficial fascia is distributed in areas which have a lot of superficial fascia, or it is very thick, and there are areas where superficial fascia is almost negligible. So you should know both these areas where superficial fascia is thick as well as thin or absent. So first we'll see where our superficial fascia is the maximum or where it is abundant. Now, when I say superficial fascia is abundant, automatically your brain should say fat is abundant, right? These are the areas which have thick superficial layer. Okay, so what exactly, or what are the areas? Now, if you open your textbook, right, you will say, okay, in front of thighs, over on the buttocks, over on the abdomen. It's very difficult to remember. Remember this, fat man. Where exactly do you see fat in this? One, over on the anterior abdomen. Second, on the buttocks. Third, on the anterior part of the thigh. Fourth, on the mammary area. Fifth, in the cervicothoracic. That means this is cervical area, the neck. Thoracic means the thorax, right? So cervicothoracic area, as well as post-deltoid area. See, the deltoid is here. There's a muscle. This is called as post-deltoid area. All of these layers, all of these areas have got the maximum abundance or thickness of superficial fascia. That is the reason whenever a person gains fat, why does that fat go into these areas only? It's because of the abundance of these cells in these areas, right? So if I tell you what is the distribution of superficial fascia maximum in the body, your answer should be it is maximum in the anterior thigh, in the buttocks, in the anterior abdomen, in the mammary area, in the cervicothoracic area, and the post-deltoid area. These are the maximum thickness areas for superficial fascia. Always remember, you have to write this in multiple lines, but the whole scenario, if you just remember this man, you will remember the superficial fascia is the thickest in these areas, right? Okay. Now, where exactly it is absent, this is also a very important, not even an MCQ, but also it is one of the very important questions asked in Vivas. Where is the superficial fascia absent in our body? Remember all those areas where the skin is very thin. Okay. Now, the first two are the two E's. What is that? If you just pinch your eyelid, that eyelid does not have any kind of a superficial fascia or fat. It is just a skin lying over a muscle fiber, right? So eyelids do not have superficial fascia. Similarly, if you see this particular thing, just touch your ears. Can you pinch them out? No. Why? Because the skin is tightly adhered to the elastic cartilage that is present below. You can't take it out except for the lobule. This is the lobule, this part. This is the lobule. Except for this part, you cannot pinch out the skin from here. That is why superficial fascia is even absent over the external framework of the ear. Now, two things related to the genitourinary tract. The penile shaft and the scrotum both don't have superficial fascia. Just remember this right now. I'll later on come into what exactly is the anatomy here. But penile shaft as well as the scrotum do not contain superficial fascia. Okay. So if I tell you four things where superficial fascia is absent: eyelids, external ear framework, scrotum, and penile shaft. These are the four areas where you do not find this kind of fascia. Okay, now you understood. When I ask you where it is abundant, that man, right? And when I tell you where it is absent, these four areas, it is absent. Okay, just remember this. Okay. Now, I already told you that their superficial fascia acts as a transmitter. It reduces friction and it gives a attachment. Okay, so I told you attachment is also a part of fascia. And what attaches to fascia? There are certain muscles which are present in this layer of superficial fascia. So this is given the name as panniculus carnosus. That means if suppose a muscle is present in this superficial layer, that particular muscle is given the name as panniculus carnosus. What does it mean? Panniculus, I already told you, it's the literal meaning is a sheet Carnosus, Latin, it is taken from the word flesh. That means a sheet of flesh, right? A sheet of flesh, if it is present, that is given the name as panniculus carnosus. Now, there are different areas of the body which contain muscle in this superficial layer. Okay, that means the superficial fascia or the subcutaneous layer or the hypodermis contains sheets of muscles. Now, where exactly you find these muscles in which areas of the body? This is also a question for you. So there are certain areas where you find these muscles. Okay, the first area is, remember this diagram, is the scalp as well as the face. The face and the scalp contain muscles inside this superficial layer or the superficial fascia. They all are present here, right? Now, this particular arrangement of muscles in this superficial layer is given the name as SMAS, or we call it superficial musculo-aponeurotic system, SMAS. Okay, so the muscles present in the face and the scalp are present in the superficial fascia, and this superficial layer is given a particular name called as SMAS, superficial musculo-aponeurotic system. This is the first layer that I'm telling you under panniculus carnosus. Okay, so superficial layer also has these kind of muscles. Now, the second muscle that is found in the superficial layer is a very important muscle that is formed in the neck. And this muscle is called as platysma. Platy means flat. If you see this muscle like this, right? It is like a flat thing over my neck. Now, what is my platysma doing? Just observe me and my neck. When I tell you to squeeze your neck, can you see this? That squeeze on your neck? That squeeze is why. That you can see these kind of fibers there. This is because of platysma. Right? So a person, when he's squeezing his neck, his platysma is becoming very, very tense. This platysma is a sheet of muscle that is present in your superficial layer in the skin and underneath the skin or the superficial fascia, right? So I've told you muscles of the face and scalp, right, that form SMAS as well as platysma is an example of panniculus carnosus. Another example of panniculus carnosus is there at the anal region, where just next to the anal opening, there is an important muscle that is called as corrugator cutis ani. Now, corrugator cutis means cutaneous, just next to the skin. As I told you, it has to be underneath the skin, right? So that is why it is cutis. Ani means anal canal. So corrugator cutis ani is a muscle which is just present at the anal opening. That is also a type of muscle that is present in the superficial fascia. Now, always remember, muscles are commonly seen below the deep fascia. There are only some muscles which are present in the fascia. That is why you need to know these names. Okay. Otherwise, all the muscles of the body are present below the deep fascia. That's a muscular framework. But these are special category of muscles. Okay. So I've already told you panniculus carnosus, examples, face and scalp, platysma, corrugator cutis ani. Okay, fine. There is also a muscle that is present around the nipple and the areola. This is called as the nipple areolar complex. So areola is around the nipple, center is the nipple. The muscles that are present here are also present in the superficial fascia. Okay. And then the last thing is that I told you that in the penile shaft and scrotum, superficial fascia is absent. Okay. So why is that? Because in the scrotum, the superficial fascia is not present. It is instead, it is a muscle that is present there. And this muscle is given the name as dartus muscle. Are you understanding it? So the dartus muscle that you see here, this is the scrotum. This is again the testes. This particular thing that we have opened up, you can see this pink colored structure. This is the dartus muscle. So the dartus muscle takes part instead of the superficial fascia that is present there. Instead of that, dartus muscles forms the lining in the scrotum. Okay, so now you understand. So what are the examples of panniculus carnosus? I've already told you, face and scalp, then comes platysma, then comes the corrugator cutis ani, then the nipple areola complex, and then the fifth one is this dartus muscle, which is present inside the scrotum. Right? Now you understood what exactly is panniculus adiposus, that means the fat, and then panniculus carnosus, which is the flesh or the muscles that are present in the superficial layer. Right? Okay. Now we have understood about what all things are there. Now let me give you a clinical scenario here. You are there as a resident you're going in the OPD, like as a first year, let's say, and you're going to the surgical OPD, and you see that a person has come to you with a very dirty wound, and his skin as well as his subcutaneous layer is all eaten up and it's smelling very bad. It's horrible to see, right? What is this called as? This is called as necrosis of the whole skin as well as the underlying structures. The fascia, the subcutaneous layer, everything goes away. So that is given the name as necrotizing fasciitis. Now you can say, what is itis? Itis means inflammation. Okay, when a particular structure gets inflamed, it is called as itis, right? So fascia, if it undergoes inflammation, it is called as fasciitis. And finally, if it is dead and it becomes necrosed and it sloughs off, it falls off, that is called as necrotizing fasciitis. It's a very common scenario where bacteria enter inside through dirty wounds and they eat up each and everything below until the level of the bone. They eat up all the flesh. A very common scenario seen in surgical practice, right? Okay. Now we come to what is the modification of this superficial fascia in abdomen. So what I have taught you till now is what is superficial fascia, where exactly you find superficial fascia, what superficial fascia transmits, what exactly is the superficial fascia containing, that is adipose tissue, and then what muscles are there in the superficial fascia. Now there is a very important question for you, that this modification of superficial fascia in the abdomen has a different name. So you know that the abdomen also has got different layers. Okay. Now this superficial fascia is given a particular name when it comes to abdomen. Only in abdomen it has been named separately. Okay. Right. So we know that there is skin on top, and then there is something yellow, and then there is something white, and finally the muscles come. In the abdomen, the superficial fascia is divided into two layers. One layer above, which is fatty, one layer below, which is membranous. Now, membranous means like a membrane. Above layer is fatty, that means it contains fat, right? So in abdomen, again, I'm repeating, the whole superficial fascia over the abdomen is divided into two layers, one layer above, one layer below. Above layer is fatty, below layer is membranous. The fatty layer in the abdomen or the superficial fascia is given the name as Camper's fascia. Camper. Okay. And then the beneath layer, below this fatty layer, the membranous layer in the abdomen is given the name as Scarpa's fascia. Trust me, this is one of the most commonly asked questions in your vivas, whenever you're getting theory exams, in your dissection halls. Favorite examiner question. What is camper? What is scarpa? You're going to rotate around these two terms a lot, right? So scarpa is the lower one, camper is the upper one. Now, how I used to remember, I used to always get confused between camper and scarpa. Who's above, who's below? Remember a camp, right? Camp, how do you put a camp? Camp, you put it over on top, right? You put a camp on top and there is someone living inside. So the camper outside, right? The fatty layer outside is camper. Underneath that, membranous scarpa, right? So always remember that camp on top, that means it's the above one. So underneath the skin, first campers, then scarpas, then underlying musculature. Okay, this is the modification of superficial fascia that is present in the abdomen, right? Now, I already told you what is the function of superficial fascia. If you just see these four things, again, they are going to come here also. The same mnemonic remains, trap, right? You already knew what it transmits. Transmission of important cutaneous nerves, vessels, lymphatics, lymph nodes, muscles, right? Reduction of friction. Why? Because it is connecting two important structures, the skin above as well as the deep fascia below. Now, just simply think of, when I'm just sitting here, I'm able to pinch my skin above. How are you able to pinch that skin? It's because you have fat beneath it. If that fat wouldn't have been there, your skin would have been tightly adherent and you wouldn't have gotten any chance to do any work. It would have been so tight. I'm able to move my fingers open and out. Why? Because I've got so much of flexibility in my structures. So reducing friction is a very important task of superficial fascia. Attachment, I already told you, it is attaching different muscles. And what are they called as? Panniculus carnosus. And I told you the group of muscles which are present in the superficial layer. And then comes, it protects you and insulates you. How? Because it is fatty, right? So what does fat do? Fat is very thick, right? So it won't allow any kind of external environmental changes to suddenly hit you. It will insulate you. It will protect you. Now, just think. You are in your dissection lab. Some of you might have also started dissections by yourselves. As soon as you cut the skin, as soon as you see the yellow fat coming, your first thing that should come in your mind is that I am at the level of superficial fascia, right? As soon as you see those blobs of fat coming, and as soon as that the blobs of fat disappear, the next layer that comes beneath it is called as deep fascia, right? So once that fat is there, think of superficial fascia, you are in subcutaneous layer. Once that fat finishes off, that white color sheath, sparkling sheet comes below, you are in deep fascia. And underneath the deep fascia, there are muscles, right? So deep fascia is a fibrous sheath. Now, how it is different from superficial fascia? The answer is here itself. This sheath is absolutely sparkling white. You will not have any kind of fat in this layer. It is tough and it is not elastic. So like what happened in superficial fascia, deep fascia is absolutely different. 4 important points. This is fibrous. It is like a sheath which wraps or invests. Okay. So this sheath wraps the organs or wraps these muscles. It is tough. It is inelastic. It is devoid or it has no fat. When you have these 4 features, that fascia becomes deeper fascia or deep fascia. And I'm going to tell you why these things are important. Tough, inelastic, no fat, why it has been given to you. It all makes sense. Okay, right. Now we move on to what is the distribution of this deep fascia. So if you have noticed, my idea of giving you the whole scenario today is in the form of question and answer. Whenever you are writing your answers, especially in your first year, right? Always remember there is a sequence of things you need to remember, right? There's a sequence where you have to write. First, you need to define, give salient points, then come to the distribution, then come to the location, then come to the modification. This is how you answer an anatomy question. Okay. So second is, what is the distribution? So like superficial fascia, distribution of this particular fascia is also on the basis of thickness. Okay. Right. Now, deep fascia is thickest or thickest at the iliotibial tract. Now, what do you mean by iliotibial tract? This particular thing is a white fibrous band. Okay, this is called as an IT band or iliotibial tract or iliotibial band. Okay, what is this? Ilio means ilium. Ilium is nothing, it is a part of our hip bone. Tibia means it's a bone that is present in our leg. A band of deep fascia present between the ilium as well as the tibia is given the name as iliotibial tract. Now you must have been sitting right now. Okay. Now once you are sitting, just squeeze your lateral part of your thighs. Okay. Just touch your lateral part of your thighs. Your lateral part of your thighs will be much stronger than the medial part. Okay. Lateral part, now you understand that is the outward part, right? Just squeeze your lateral part. It will be very thick. It will be very strong. That strength is given by this IT band or iliotibial band or tract. This IT band is the thickest part when deep fascia is concerned. MCQ. Which is the thickest part of deep fascia? IT band or IT tract, right? Where is your deep fascia absent? 2 important things, 2 important words. One is face, another is ischiorectal fossa. What is ischiorectal fossa? Nothing. Ischium is a bone that is in the pelvis. Rectum is again, that is the last part of your intestines, right? There in your pelvic area, there is a fossa or there is a small triangular shaped space that is called as ischiorectal fossa. Right now, I don't want you to go into ischiorectal fossa. It's a different chapter in perineum. But just remember these 2 terms. Absence of deep fascia is seen in face and ischiorectal fossa. Right? Okay. Thickest IT band, IT tract, that is iliotibial tract. Okay. In the neck, this particular deep fascia is in the form of collar. That means this particular deep fascia is like a collar like this. It wholly like my collar is like this. This is my deep fascia of the neck. It comes like a collar. Now this collar is called as investing layer. These are all important MCQs. Okay. So just imagine something like a collar is investing my neck. Investing means it is catching my neck, right? It is covering my neck. If it's investing my neck, what it is called as? It is called as investing layer of deep fascia. Correct? So if I turn my collar like this, you should say that is my investing layer of what? Of the deep fascia. So it is in the form of a collar in the neck. Okay. Then comes, it is not very well defined in the trunk. And I already told you it is absent on the face. So why it is not very well defined in the trunk? Trunk means the abdomen, because the superficial fascia is there with two layers. Now you understand the superficial fascia that we already discussed. Campers above, scarpas below, that is more defined there in the abdomen, but the deep fascia is not very well defined in the trunk. And it is very, very well defined in the limbs. And I'm going to show you that how exactly this deep fascia is in the limbs. Okay, fine, clear? So according to the distribution, you should know where all this is, right? Now let me show you some pictures. This I've already showed you. A band that is present between the ilium as well as the tibia, that is called as an iliotibial tract or an IT band, which is the thickest part of deep fascia. See this particular thing, right? This is your neck. This layer of muscle I've already told you that is in your superficial fascia. What is this muscle? The platysma, right? This is from Netter, which is very important atlas for you. So this is the platysma. That is like a sheet. Now, if you remove the platysma, what is going to be there below? Definitely it is going to be deep fascia, right? And I told you this is a shiny, sparkly white fascia. You see here? And this forms like a collar. See, it is coming like a collar. This is the deep fascia of the neck, not the pink one. Pink one is the platysma. The white color shiny fascia that is present below this. This is the investing layer which forms a collar of the deep fascia, right? Understood? Okay. Now I come to a very, very important part, and this is your favorite first year anatomy question. That is why I've marked 4 stars here. Every college, every student faces this question once in a lifetime in his anatomy papers. Okay, so when you read your textbook, what I found was that this particular question has not been written very well in textbooks. So what I have done today is I am going to give you headings to write this question in your exam. So if you are asked modifications of deep fascia, you should start with distribution. And then after that, in the modifications, I have given you 7 headings under which 7 types of modifications of deep fascia you can write and you can score marks easily. Okay, so you just need to just think here, memorize later on. Okay, just understand what I'm trying to tell you. Right now, this first modification of deep fascia is in relation to muscles. Okay, this is how you have to put headings. First heading is in relation to the muscles. What is the modification? Now see this. Okay, what I've done is we have taken a cross section of this particular leg. Okay, so you are seeing this is the muscle. You have seen 2 bones, that is your fibula here and your tibia. So tibia and fibula are 2 bones that are present in your leg, and we have cut the leg horizontally, or we have cut the leg transversely, or in an axial plane. This is called as an axial plane. So once we cut anything in an axial plane, what we are seeing something from the top. Now imagine I've cut my neck and I'm seeing something from the top. The cut end of my neck is seen from the top. Similarly, what I've seen, it's seen here, right? When I've cut it like this. Now, you know, the outside layer is called as the skin. We have already discussed that after that, there is a fatty layer, which is of superficial fascia. So you see all the superficial fascia. And then deep to the superficial fascia, the green color band is the deep fascia. So the first modification in relation to the muscles of deep fascia is this deep fascia tightly invests over the group of muscles, and it sends off these kind of separations inside these areas. That means this particular deep fascia divides the whole limb into compartments by sending these partitions. These partitions are called as intermuscular septa. That means septations present between 2 muscles. Now, who's forming these septa? Septa is being formed by deep fascia. So the first modification of deep fascia in relation to the muscle is formation of intermuscular septum. Now, why exactly this intermuscular septum has been given to you? If you closely see this leg, these intermuscular septum contain very important vessels, nerves going through them. So intermuscular septum, A, divide the whole limb into compartments, 1 compartment anteriorly, 1 compartment posteriorly, 1 compartment laterally, 1 compartment medially. That is why whenever you're reading limbs, you will see anterior compartment anatomy, posterior compartment anatomy, or let's say extensor compartment anatomy, flexor compartment anatomy. Why is that? Because this deep fascia is giving off intermuscular septa, which is dividing this whole limb into various compartments. See these compartments. You can see 1 compartment here, 1 compartment posterior, 1 compartment here, right? So this compartmentation is done by intermuscular septa. Why it is important? Because this carries important blood vessels through it, as well as nerves through it. So they pass through these compartments, okay, through them, right? Because any muscle cannot have an artery passing through it. You cannot have. You should have some space through which it passes. So that is an importance of, in relation to muscle, the modification of deep fascia. Now, not only this deep fascia forms important compartments by these septations, but also it lines muscle fibers. Okay, so if I've taken out, let's suppose this was the muscle, I've taken out this muscle, and this is the whole muscle that is in front of me. The deep fascia covers each and every part of the muscle also. That is the modification. Now, each muscle, if you see that each muscle has got multiple of these small nerve fibers. Okay, so let's say this is one muscle fiber. Once multiple muscle fibers get clubbed together, we give it a name as fascicle. That means if I have one finger, I will say this is my one muscle fiber. This is lined by deep fascia. Okay. Once I have multiple of these of these muscle fibers like this, I grouped them together. I call the whole bundle as fascicle. Okay. And then multiple bundles together. That means this is my one bundle. This is my one bundle. Both come together. This will again be wrapped, and this will form the muscle, the main muscle bulk itself. So are you understanding? There is something called as a muscle fiber. Then after that, there is something called as a fascicle, which contains multiple muscle fibers. And then there is multiple bundles create the muscle. Okay. Now, why exactly deep fascia is important here? Each muscle fiber is lined by layer of deep fascia. Each muscle fiber which is lined by deep fascia lining is given the name as endomysium. Mysium is a muscle, endo means inside. So the layer of deep fascia which lines each muscle fiber separately, this is given the name as endomysium. Okay, fine. A layer of deep fascia which covers a group of these muscle fibers, that is lining the fascicle, that is given the name as perimysium. So see this is a particular lining of multiple muscle fibers together. This is called as perimysium. Peri means above the muscle, right? And when all of these muscle bundles are together wrapped in a lining, this is called as epimysium. So there are three mysiums. Each muscle fiber is lined by endomysium. Collectively, those muscle fibers come together to form a fascicle, which is lined by perimysium. And once all these fascicles join together to form a muscle bundle, the whole muscle is lined by epimysium. Okay, endo, peri, epi. Three layers. If you remember this, you'll remember the nerve also. So remember this: first endo, then peri, then epi. Okay, so what is the modification of deep fascia in relation to the muscles? It is forming intercompartmentalization by the help of intermuscular septa, and it is also lining each and every muscle fiber, muscle bundle, and it is around the whole muscle, right? In the form of endomysium, perimysium, and epimysium. This is the modification of deep fascia in relation to muscle. So my first point gets completed here. First modification done. Now we come to the second modification. Second modification is relation or modification of deep fascia in relation to blood vessels. Okay, this is how you have to write the answer. That is why I made it very simple for you, because otherwise in textbooks, it's haphazard. Okay, now in relation to blood vessels, why do you need fascia? First of all, your blood vessels are passing through various structures of the body. They cannot be lying naked. Why? Because if suppose there is any kind of an injury, if there is any kind of a trauma, these vessels are likely to get injured very easily. So you need a covering over them. And that is why deep fascia is covered in the form of sheaths all around these blood vessels. Now, if this blood vessel is in the neck, right? This is an example. If these blood vessels are in the neck, we call it a carotid sheath. Now see this is a carotid sheath. It has got carotid artery, it has got vagus nerve, it has got internal jugular vein. So here, if I say here, my carotid sheath, my vagus nerve, and internal jugular vein, all are running like this. Here three, and they are all covered in a fascia. What is that fascia called as? Carotid fascia. And why do you need this fascia? For protection of these vessels as well as nerve. as well as nerve fibers, right? If this fascia is not there, what will happen? Suppose if I get an infection of a throat and it somehow forms an abscess or pus comes out here, if this fascia is not there, all my carotid artery, all my jugular will get that infection because the fascia is protecting it. You remember trap, P, protection. This is why protection comes, right? Okay. Now I come to another example here. This is an example of a femoral sheath. Now sheath is again a wrap, a covering, right? So the deep fascia also forms an important covering around femoral vessels. Femoral means in the thigh. That's the femoral area. So you see here, this is the femoral artery, this is the femoral vein, and this is a lymph node. This particular deep fascia, you can see here, also wraps around femoral vessels and creates these kind of compartments. One compartment inside, medially, one compartment in the center, one compartment laterally, so that all of these vessels are protected. Now, one point here to notice. The deep fascia around the veins is less dense than the deep fascia around the arteries. That means the deep fascia around the arteries is much more wrapping around, or it is much more inelastic than the deep fascia that is present around the veins. Why? Because veins distend. If the veins distend, they need space. That is why if you see particular here, this vein has a caliber, and see the space that the deep fascia has been given. That space has been given so that the distension of the vein when it carries the blood is easily there. Okay, so around the veins, the deep fascia is less elastic, more elastic, as well as around the arteries, it is more densely packed. Remember this. Okay, now this particular thing is a very common thing that you see in a clinical scenario. I'll tell you that clinical scenario. The medial most portion of this femoral sheath is called as a femoral canal. And see, this femoral canal only has a lymph node. Now, why this deep fascia is important? Here it comes. This clinical scenario. Now, suppose you find a person who is a heavy weightlifter, okay, and a heavy weight lifting causes an increase in the intra-abdominal pressure. And once that intra-abdominal pressure increases, likely the intestines or the viscera might protrude out through these channels or canals that have been made by the deep fascia. And this is called as femoral hernia. Now you understand. What is the clinical significance of this particular herniation? Hernia means what? Hernia means when a normal structure protrudes out of an artificial opening. That's called as herniation. So when this intestines, they get out because of increased pressure, because of increased intra-abdominal tension through these weak spots that are present in the deep fascia, that is given the name as femoral hernia. So in this particular case, the femoral hernia will come out of the femoral canal if this femoral canal is not very well formed. That means if the deep fascia is not well formed here, there are likely chances that this intestine will come down and it will present like a swelling in the groin, right? That is the importance of this particular sheath that is present or which is covering these vessels. Okay, so now I've told you two important modifications. One modification is in relation to blood vessels and one is in relation to the muscles. Okay, right. Now we move on to the third type of modification. Now, if you remember the muscle, you will remember this also. Same thing. Okay. Now, what exactly makes the nerve? Now, see, this is also exactly like the muscle we spoke about, right? What exactly it is a nerve? The nerve has got various nerve fibers. Each nerve fiber is surrounded by a deep fascia, which is called as endoneurium, same as endomysium. Okay. A group of these nerve fibers are together forming something like a fascicle, and this is lined by perineurium, and the whole lining of the nerve is by epineurium. The same what we read in muscles, the same thing comes here. Only the mysium that was present there because of the muscle, it changes to neurium, which is literally meaning nerve. Correct? So the main relation to the nerves is, you should say that the deep fascia in relation to the nerves lines each nerve fiber, which is called as endoneurium, a group of nerve fibers, which is called as a fascicle by perineurium, and bundles of these fascicles together, which is by epineurium. Now, how you relate this in a clinical scenario? Let me take you here. Okay. So idea of teaching today this way is, whenever you are reading anatomy, you will get maximum marks if you give a clinical situation with your answer. So if you're writing deep fascia, whatever clinical scenarios I've told you, Just example them and name them. You will get at least 5 marks extra than what you're getting. This will be a long question for you. So you will get that extra point if you answer this way. Okay, fine. So let's say the clinical scenario here. Okay, so there was a person, his name was Sedon. He classified peripheral nerve injuries on the basis of this anatomical knowledge. What we have: endoneurium, perineurium, epineurium. On the basis of this, nerve injuries can be classified. So the innermost layer is endoneurium, you know, then above that is perineurium, above that is epineurium. Now, if suppose, okay, suddenly I'm standing in front and something hits me here. Okay, so blow. Now, if that blow is there, some or the nerve fiber will get compressed. Now, if that nerve fiber is getting compressed, this particular thing is called as neuropraxia. That means all my layers of the nerve are intact, but the conduction of the nerve will not take place because of injury. It is still intact like this, but all the layers of the nerve is intact. But there is some kind of an injury over the nerve, so it has become a little bent. But still, it is working. But it is not functioning as if something is working normal. That is why you tend to feel numb. Whenever something hits you suddenly, why you feel numbness, and why does that numbness come after some time back to normal, is because of this transient neuropraxia. That means there is a conduction block for some amount of time, but after that it will improve because all the 3 layers of the nerve are still intact. Second thing is called as axonautomesis. What do you mean by that? That means if this is a nerve, this is the center part of the nerve which is called as an axon. If suppose you have injury to the endoneurium, see, endoneurium is damaged, but still the perineurium and epineurium is not damaged. This is called as axonautomesis. And finally, there is something called as neurotomesis, where there is completely, the nerve is in 2 segments. That means all the 3 layers, the endoneurium, perineurium, and epineurium, are completely transected out. So this is the classification of nerve injuries as far as clinical scenarios are concerned when you have Sedon's classification. So first is neuropraxia, that means a conduction block where all the 3 layers are still existing. Axonautomesis means only the axon or the center part of the endoneurium of that nerve is damaged. And neurotomesis means completely all the 3 layers, perineurium, epineurium, and endoneurium, are damaged. And finally, the nerve is dead. It has got nothing to do now. Now, are you understanding how these clinical scenarios work? Right. So we have done 3 modifications already. Now, let me take you to the 4th modification of deep fascia. That is in relation to the joints. Okay. So that is why I told you this is an interesting topic if you take it one by one and try understanding it. Otherwise, it becomes very boring and very difficult to understand also, because in textbook, you'll just see text, right? Okay. So the 4th modification is here. Now, the deep fascia modifies itself at synovial joints. We're going to take synovial joints as a separate topic. Don't worry. I'll tell you what is a synovial joint. You see this knuckle of mine? You see this knuckle? This particular one bone to another bone, when it attaches, it is called as a joint. Joint is nothing but one bone to another bone that is attached together by something called as a joint, right? Now, once these joints are present, they have a space in between them. This space between the joints is called as synovial space. And that is given so that one bone can move over the other bone. If the space is not given, the one bone will cause a lot of friction. That is why now I come to trap again. So what was the R? Reduction of friction, right? So why is it been given? So deep fascia is also reducing your friction in these synovial joints. Example, knee joint. That is why you're going to move that. Now, how does that deep fascia come into play here? Okay. Now, the deep fascia basically modifies itself and forms a very important structure in synovial joints that's called as an articular capsule. Articular capsule. Articular means 2 surfaces once they come together. That's called as articulation. So this is called as an articular capsule or the joint capsule. Joint capsule has got 2 parts. One part, you see this blue color thing. This is called as a synovial membrane. And once you see this thing, this color, this purple color, this is called as a fibrous capsule. So the joint capsule has got 2 parts. One part inside, which is called as a synovial membrane. Other part outside, which is called as the joint capsule or the fibrous capsule, right? The fibrous capsule outside, membrane inside. This synovial membrane releases a very important fluid in this synovial cavity, which you see blue in color. This is called as synovial fluid, right? And then this synovial fluid also forms important bag-like structures. So bags of synovial fluid on the sides of the joint is called as bursa. Bursa. So now let me just take you in a crux, okay? Don't get confused. The deep fascia modifies itself at the level of synovial joints by creating joint capsule, which has got two parts, outer fibrous part, inner synovial membrane. Synovial membrane creates synovial fluid, and it also, the deep fascia forms bags of synovial fluid on the sides of the joint, which are given the name as bursa. So it is forming what all? It is forming synovial membrane. It is forming joint fibrous capsule of the joint. It is also forming something called as bursa. Correct? So these are the three important things that the deep fascia is basically forming in relation to the joints or the synovial joints. Now, why is it important? Because this particular synovial variety of joint is basically carrying, or it is reducing, the friction between two articular surfaces. That is why it is important, right? Okay, now let me give you a clinical scenario. In your everyday life, you will find a 65-year-old or a 70-year-old suffering from something called as osteoarthritis. What is that osteoarthritis? The deep fascia modification that is present, that is making the bursa, that is making the synovial membrane, that is making the joint capsule, is not present. So two surfaces or two bones are now rubbing against each other. So what is that friction causing? That friction is causing arthritis. Arthra means bone, itis means inflammation, two bones getting inflamed because the synovial membrane is not present at all. Correct? Now you understand in clinical scenarios how this works? Right. Now let's move on to another type of this modification, which is found over in relation to the joints. Okay? Deep fascia thickens at specific places which are called as retinaculum. Okay? Now, what do you mean by retinaculum? Retinaculum means retinere. Okay, retinere is a word which is a Latin word which is called as nothing, which is called as a sheet which protects or a sheet which retains. That is why it is called as retinere or retinaculum. So deep fascia gets thickened in relation to joints to form these important retinaculum. Now see this retinaculum, see this retinaculum. Why this has been present? If you see this retinaculum, beneath that there are so many important tendons, so many important nerves and vessels which are passing. So this retinaculum is nothing, it acts as a pulley. This is the literal term, the pulley, so that various tendons, various blood vessels, nerves, lymphatics can pass and they don't get damaged. Right? So they are also present over on the wrist. They are also present over on the plantar aspect or on the foot. Now let's say this is my wrist. Okay. If I just extend my wrist, you see multiple tendons here. Now these tendons are very, very thin. Okay. What is a tendon? Tendon means which source which attaches a muscle to a bone. So these are muscles which are basically forming these tendons, and these tendons are attaching here in the hand. Now, if these tendons are left exposed just like that, if I just put my wrist down, I will feel so much of pain, so much of nerves will get compressed that I won't be able to feel anything in my hand. So I need a structure which to prevent it. That is why this retinaculum or a pulley has been given, so that all my structures beneath are prevented. The tendons, the blood vessels, the nerves which are passing below. Right? So this particular structure or a modification of deep fascia is called as retinaculum. So I covered what? I covered muscles, I covered blood vessels, then I covered muscles, the nerves, right? Then after that, I'm covering about joints, and I've covered about retinaculum. So now you understood how to write these answers. Okay. What is the clinical scenario here? I told you this flexor retinaculum is present here. It has got very important tendons as well as very important nerves as well as vessels passing underneath it. Okay. Now, in some particular conditions, this flexor retinaculum becomes very, very tense and hard in some people. And what happens? There is a very important nerve that travels in here. This is called as the median nerve. Okay. Am I audible?
Yes, sir. There was a small cut, but still now it's
Yeah. So there is a very important nerve that travels here. This is given the name as median nerve. Now, what exactly that median nerve is? The median nerve supplies my thumb, index finger, middle finger, as well as ring finger. This is all supplied by the median nerve. Now, if suppose any flexor retinaculum gets damaged here, I will have numbness in all of this. This is given the name as carpal tunnel syndrome, right? Carpal tunnel syndrome. Am I audible, Aishwarya?
yes, sir. You are audible.
Yeah, because I think there's a some
Yeah, I
light
got it. I
issues.
got it. But
Yeah,
there is no issue,
yeah.
sir.
So this is called as carpal tunnel syndrome. So if I have a person with carpal tunnel syndrome, his all these areas will be numb. Why? Because his flexor retinaculum is actually pressing that nerve. Similarly, if you see here, compressed median nerve, and see this flexor retinaculum is right above it. Now you understood. So don't think that this flexor retinaculum or retinaculum is just present here. It is present here. It is present here. It is present over on the distal aspect of our feet also. Everywhere where tendons are passing, it is present there. Right? Okay. So now we have done this modification also. Now I come to the fifth modification of deep fascia. The fifth modification of deep fascia is in relation to the palms and soles. Okay, the palm and the sole. Now, if suppose I'm asking you this question, you are here and you stretch your palm. Can you feel your palm here in the center? You will feel that this particular area of the palm is very, very thick. This thickness of the palm is given by something called as an aponeurosis. Aponeurosis. That means there are certain specialized modifications of deep fascia which are present over the palm and the sole, which are nothing but they are thick slips of fascia. So my fascia is coming like this and it has become like a thick slip over on my palm, over on my plantar aspect or my sole, just like this. Why these facial modifications have been given there? So that because you are using your palm and your soles all day, every day, and this is the maximum area of friction. Your underlying tendons and vessels and nerves will get damaged. Suppose if I slap someone, so if I'm slapping someone, if I don't have this palmar aponeurosis, all my tendons will get that numbness. My nerves will get compressed, right? So it has to have some kind of a covering here. That is called as an aponeurosis or a palmar aponeurosis. Palmar means, again, your palm. Plantar aponeurosis, that means on your feet. Correct? So these are the modifications that have been given to you over on these areas. These are called as aponeurosis. That means these are bands which go and attach to digits. Correct? Fine. So now we have done 5 modifications. What is the clinical scenario of deep fascia modification when it is related to these? Okay. There is a very interesting thing that is called as a Dupuytren's contracture. What is a Dupuytren's contracture? Dupuytren's contracture means this is particularly seen in alcoholic people. So those people which are alcoholic or have some kind of a history of diabetes or are immunosuppressed, in those people, this palmar aponeurosis becomes very thickened because of an unknown cause. Because if this palmar aponeurosis will become thickened, see what will happen. My little finger and my ring finger will come towards flexion. This is flexion, right? So this is what? This is your metacarpophalangeal joint. They will cause flexion at the metacarpophalangeal joint in the last 2 digits. And this is what exactly you see here. This is called as a Dupuytren's contracture. Very, very common in alcoholic liver disease. Okay, you see this kind of features, right? Now you see each and everything with a clinical example. This is how you have to write your answers. It gives you a very good insight as well as very good marks. Right. Now we move on to the second last of our aponeurosis of deep fascia, that is in the abdomen. Right? Okay. As I told you, abdomen is something which has lack or the deep fascia in the abdomen is not very well formed. If you remember my distribution part, I told you the abdomen is the area where superficial fascia has got 2 layers, campers and scarpas, but the deep fascia is not very well formed. But you need to have a fascia there also, right? You need to have a modification. If the fascia is not present, then it has to modify, because abdomen is something which is protecting our viscera or our important organs below, right? So in order to do that, the fascia is very smart. Deep fascia said that if I am not myself present there, I will modify and present myself. And this modification is also in the form of aponeurosis, as I spoke to you in palms and my plantar aspect. This aponeurosis is basically formed by expansion of sheets of three important muscles of the abdomen. So I told you abdomen is made up of a lot of muscles. Three muscles make the important part of abdomen or abdominal wall. Outer part of the muscle is called as external oblique. If you cut the external oblique, you will get internal oblique. If you cut the internal oblique, you will get something called as transverse abdominis. Now, don't get confused. Why they have been given their name? See, this is external. This is coming obliquely, external oblique. See this. This is internal because it is inside. It is coming obliquely. See the fibers. That is why internal oblique. And see, this is transverse or horizontal. That's why transverse abdominis. This is how things are named. As simple as that. So if these three muscles are present here, they expand and form these kind of white sheath. They form these white sheath in order to get this strength over on the abdomen. See this white sheath here? This white sheath is basically called as an aponeurosis. Or this is given the name as a rectus sheath. So this center muscle is called as rectus muscle. Over that, there is a sheath, and this sheath is formed by three important muscles, which is external oblique, internal oblique, and transverse abdominis, which together form these kind of aponeurotic bundles, and they form a covering over the rectus abdominis, and this is called as a rectus sheath. Now, imagine someone who has got a lot of abs. You must have seen that the abs have got two abs above. I've got six pack. What do you mean by that six pack? 1, 2, 3, 4, 5, 6. How do that compartmentalize? Why does that compartment come? You can count the abs. It's because of this aponeurosis. See, you can count now. You can see because of this sheath and this expansion, which is forming something called as a rectus sheath. Now you understand, right? Now, if suppose this rectus sheath is not formed, these areas of the abdomen will become very lax and they will become very, very loose. And if there is anything inside which is causing a tension in the abdomen, they are likely to get protruded out. See this? Suppose this baby is born with a congenital defect over his anterior abdominal wall. All his abdominal viscera will start protruding out through this. And this is called as what? This is called as umbilical hernia. Hernia is what? Protrusion of normal structures. Correct? So now you understand what exactly is causing there. So as I spoke to you about femoral hernia, you remember femoral hernia when I spoke to you in relation to the blood vessels, the deep fascia modifications. Similarly, if this particular sheath is not formed, see, all of this intestines or viscera are going to get protruded out through this natural orifice and produce as a swelling just next to the navel. And that is called as umbilical hernia. Got the idea, right? See how simple it is if you see such examples and if you understand and read it. Okay, fine. Now, last modification of deep fascia. That is why it's a big topic, but it is an extremely interesting topic if you understand. Last part of deep fascia modification is something called as an interosseous membrane. Again, simple. Inter means between, osseous means bone. Sometimes there is a fascia or a modification of deep fascia that is present in between two bones. And this is called as an interosseous membrane. Simple, right? So this is a bone that is radius and this is ulna. You will read in your forearm when you read it. So the thumb part here is my radius. Here on the other side is my ulna. And in between my radius and ulna, here in between somewhere, this is the part where this interosseous membrane is present. Correct? Now, what is the function of this interosseous membrane? Why it has been given to you? That is your second question. Now, think. One, this maintains a gap between the two bones. It is definitely, if my interosseous membrane is present, then my both bones will not come together and join. They won't cause friction. Otherwise, if they have friction, I won't be able to move my hand like this. Can you see my hand moving like this? This is what? This is pronation, supination, right? So if I'm moving my hand, the ulna and the radius are rotating around this interosseous membrane. This is one thing. So it is maintaining a distance between radius and ulna, or let's say between two bones. Second, it is causing decrease in the friction between two bones, right? Third function of this interosseous membrane is that it gives attachment to muscles, because some muscles attach from here to the radius, some attach from here to the ulna, right? And fourth is, you can see these kind of gaps in between. This interosseous membrane gaps help in basically traversing or transversing vessels through them. So vessels from the posterior part can enter the anterior part through this. It cannot cross the bone directly. It has to pass through some structure which has a hole. This membrane has a small hole, so it will pass anteriorly and it will start supplying here. Or some anterior vessel can go posteriorly and start supplying the posterior part. That is why this interosseous membrane has been given to you. So I told you about the functions. 1, it maintains the gap between the two bones for functioning. 2, it helps reduce the friction. 3, it gives attachment to muscles. 4th, these foramina are basically meant for traversing all the blood vessels and nerves through it. Got the idea? So now I have told you lots and lots about deep fascia, but this is a very important topic. So I come to the last part, the last slide, which covers each and everything in detail about superficial fascia and deep fascia. Again, my mnemonic is here. Just think of the same mnemonic trap. So what functions did the deep fascia perform? A, transmission. You saw a lot of vessels and nerves passing through that. So example, a retinaculum. Now you know retinaculum is a fibrous sheath. Retinaire, I told you, that is functioning as something to retain. So important tendons, vessels, nerves are passing underneath the retinaculum for protection. So A is transmission. R is reduction of friction. So I already told you how it is reducing the friction. I told you an example of joints, synovial variety joints, right? I told you an example of interosseous membrane. The friction between two bones is prevented, correct? Similarly, I told you about A, attachment of muscles. So muscles can take or arise or attach to some modifications of deep fascia. Example, interosseous membrane. I told you there are some muscles that can attach from the radius to the ulna and down to the interosseous membrane. And P, last is protection. Protection, I told you, palmar aponeurosis, right? Plantar aponeurosis, the aponeurosis that is forming in the abdomen, forming the rectus sheath, right? They are all protecting our underlying things, which are important organs. Here in the palm, they are important tendons. In the abdomen, they are important organs, correct? So these are the functions. If you just remember TRAP, all the functions will come to you, right? But you have to create that concept inside before going into the details and before reading into it, right? So I think we have finished up with the deep fascia and the superficial fascia in detail. And I would like Aishwarya to come in because it's time for my ward rounds. And I would give you clinical scenarios. I would give you real-time patients so that you could actually think of and answer me as to what do you think and how we can revise this topic in just 5 minutes. Okay. So I think Aishwarya is there. So it's time for revision.
So before we move on, I think we have Binit Sai.
Yeah.
So can you please say the two types of modifications of deep fascia in relation of blood vessels?
Okay, so in relation to the blood vessels, I told you about the femoral sheath, Vinith, okay, where you have these femoral vessels passing through it. Second, you have carotid sheath, where you have these carotid artery, internal jugular vein, and vagus nerve, which passes inside it. There is also something called as an axillary sheath. So just to make it simple, 3 examples you mentioned: axillary sheath, femoral sheath, and carotid sheath. That is more than enough. Okay.
Thank you, sir. I hope, Binit, your answer is clear. So that if we can move on to the ward rounds.
Yeah. So let's see. And let's get our first scenario. And I want people to participate because this is a kind of revision activity for you. Okay. So the more you participate, the more you revise. Okay. And I promise you everything will be revised by the time you go back. Which modification of deep fascia is going to affect this function? That is something supination and pronation. So let me see fastest finger first. Which modification of deep fascia is going to affect this particular function? What do you think?
You can comment your answer.
Anyone can put their answers in the comment section. We have done so many modifications. Okay, we have got pouring answers, but whoever answers first is the winner in my round. Yeah. Okay.
Here we have Shubham, who has answered first as interosseous membrane.
Great. So I think we have got a lot of right answers, but Shubham gets the point because that is how you have to make a practice of MCQs. You have to be very, very fast if you know a particular thing, right? So interosseous membrane is the right answer. I told you between two bones, which particularly makes this function a lot easier, pronation and supination. But don't misunderstand that interosseous membrane is the only one which is causing this. Okay, there are many muscles also which cause this kind of a function, but interosseous membrane is also one of the things which helps you in pronation and supination. Okay, remember this. Okay, now let me move on to the second scenario of the day. Which modification of deep fascia is going to affect this function? So this is a particular patient who has got this kind of a drinking habit. He develops liver cirrhosis, right? And he also presents with this kind of a hand deformity, where I see this kind of hand is there. So which modification of deep fascia do you actually think of which has gone wrong here or affect this? Is answer?
Yes, Shubham has answered first with palmar aponeurosis.
Okay.
And we have Samreen also answering the same.
Okay.
Following that, we have Vinayak who has answered retinaculum.
Okay. So again, Vinayak, retinaculum, when you think of, remember the wrist and the plantar aspect and the part where your ankle joint is. So my ankle joint and my wrist joint are the ones which contain that retinaculum, because all my tendons are passing through here. When it comes to the palm and the plantar aspect, they are aponeurosis. Okay, don't confuse. Plantar is foot, palmar is here, aponeurosis. This is the reason why we get this kind of a contracture. So what is this contracture? Anyone can name this contracture?
Yeah, we have someone who has named it, sir.
Yeah.
Shubham himself has named it.
Great. So
Dupuytren's
Shubham has named it and it is called as a Dupuytren's contracture. Brilliant. So we have got a surgery where we release this band. It's a very, very debilitating condition. People, when they drive, right? So they have got this kind of finger contraction and they can't drive or they can't carry out their regular activities like writing also. Okay, that is why we need to release this kind of a band of palmar aponeurosis. Right, great. So now we move on to the next question. You are in the dissection class and you are given a scalpel that day. You're lucky to get the abdominal wall dissection. And what do you encounter below the skin? See, you have something gray, you have something yellow. So I want both the answers. What is the yellow part and what is the gray part? What exactly is the first one is the yellow part and what is the gray part when you're giving the abdomen? This is a modification of superficial fascia. So what exactly is there? Answers are there.
Yeah, answers are there, but someone who has
great. I think everybody has understood this part. Yeah. So again, campers and scarpas, everybody is right? Campers is again yellow. Scarpa is the membranous one. That is below. Camp means above. Scarpa below. That is how we remember it. So great, right? So abdomen, remember, these are modifications of superficial fascia, not the deep fascia. Remember that, right? Deep fascia modification is the rectus sheath. That is in the abdomen. Okay, fine. Now we move on to the next clinical scenario. What variety of gland is mammary gland? Right. So I told you when I was reading superficial fascia, I said I'll come back to this because this is one of the most. Yes, sweat.
Okay, we have Vinayak saying sweat.
Sweat gland.
John saying apocrine. Sony,
okay.
apocrine, Vahini.
There are so many people who have actually answered it right, if I'm not wrong. Okay,
yeah.
Everyone is right because it's very difficult to pick out the right out of all because everybody is right. So that's good actually. I'm very, very happy that people are all are right. If one is wrong, I'm sad, but all are right. That is the best signal for me. So it is a modified sweat gland. Okay, students, remember this part. Modified sweat gland, apocrine variety. Apocrine variety, modified sweat gland. Right? Just simple as that. So it is in the superficial fascia. So this is one of the glands which is present in the superficial fascia. Correct? Right. Now, next question is, which modification of deep fascia is going to affect this function? So there's a person who has a median nerve which is compressed at the wrist and it is resulting in numbness and pain. And even I want students to actually tell me what exactly is this particular syndrome called as.
Samreen has answered retinaculum first, following Vinayak, retinaculum.
Somebody has answered what exactly is a syndrome?
Carpal tunnel syndrome is answered by Vahini, sir.
Great, Vahini. It is the right answer. And whoever has got flexor retinaculum, that is also the right answer. So whoever answered flexor retinaculum first, Samreen, I think, that is also right. I see.
Sir, Samreen has answered retinaculum.
Okay, so who has answered flexor is Shubham, I think.
Flexor retinaculum, yes.
Correct. So whoever has answered flexor, okay, flexor. See, this is flexion, this is extension, flexor, okay, flexor. Flexor compartment, flexor retinaculum, and median nerve gets compressed. And I told you, half of a finger on the ring, both your the first finger as well as the middle finger as well as the thumb, they all are supplied by the median nerve, and this has this kind of a numbness, which is given the name as carpal tunnel syndrome because it's like a tunnel, right? Okay. Now we move on to the sixth scenario for today. So you are in an OPD in surgery and you are presented with a patient with extreme groin pain, right? You examine the patient and see this kind of a swelling in the inner thigh or the groin area. Now, what exact modification do you think is here in this patient? First, two things. What modification of deep fascia? What is the pathology?
Okay. First person to answer is Karani, who says hernia. Shubham
Okay.
says femoral sheath. And Sony says femoral hernia.
Okay. So first I'll say, let's say, what is the basic modification of deep fascia? So we will call it femoral sheath, right? That is a modification of deep fascia. What is the pathology behind it? That there is something called as a femoral canal. That is the medial most portion of that femoral sheath, which in some cases is enlarged than the normal, and the viscera of or the intestines or any abdominal viscera can protrude out because of increased intra-abdominal pressure, and that is called as femoral hernia. Great, guys, great. I'm really happy that you know these clinical scenarios, because this is how you have to think and link it to a clinical OPD. Okay, because you will be posted in such departments and you will be getting these kind of scenarios. Okay, so now you can tell that resident straight away that I know this and I know my anatomy well. Okay, thickest part of the deep fascia is seen in. What is the thickest part of deep fascia? What is this called as? Thickest part of deep fascia is called as.
Sony has answered as IT tract first.
IT tract. Okay. Oh, something. Okay. So I see some kinds of. Somebody is calling it an iliotibial band. Somebody is calling it an iliotibial canal.
Tract.
Somebody is
Then
calling it a tract. So don't forget
iliotubular.
this. Yeah. So this is called as an IT band, or you can also call this that it is an iliotibial tract, right? So don't call it a canal, right? So because this is something like a band, that is the best word to use is a band. Okay, so call it an IT band, that is the safest. Okay, between the ilium as well as the tibia. So IT band is, yes, it is the thickest part that is present in between the tibia and the ilium. That is on the lateral aspect of the thigh. So you can see this particular thing that is present on the lateral aspect. Now, here only, students, I am going to confuse a little bit. Can you tell me two areas where you don't find deep fascia? Let's see who answers it.
Vinith has answered first as face.
Okay.
Preeti face. Narendra cornea.
Not the cornea. Cornea is eye. Eye. Don't confuse eye. Cornea is a separate thing. Okay, cornea is not got to relate with the skin, right?
Somebody says face and ischiorrectal.
Yes, face and ischiorrectal fossa. These are the two answers, right? So don't get confused. Don't even if you have not got the answer right, don't get disheartened, because this is something you are trying at least. I really like the students who try. So you have to try a lot in order to get anatomy. And I'm really telling you, anatomy was my biggest fear when I was in first year. Was my biggest fear. It took me a lot of time to actually capture it. And then I thought it is the easier subject to capture, because we don't understand. We kept on mugging. It wraps out by the end of the day. Right?
Sir, sorry to interrupt. I really know it's time is really up, but I would just like to know why some of them answered few answers. Like Shubham has answered skull. I would just like to know like what actually they feel. Why is it so? So can we unmute Shubham so that we can get to know why did he feel so? Shubham, can you just try to unmute yourself?
Don't worry. This is not your professor.
Don't worry. Come on, let's speak.
Because
let's
we want you to actually get that understanding of everything.
Yes. We would like to know why are you thinking like that, so that we can, make it more better.
I'll correct you out.
Yes. Shubham, can you just unmute yourself and talk? Are you able? Yeah. Come on.
Ma'am, I thought that sir told along with the face, the skull is also included.
Yeah, that is in superficial fascia. Okay. The face and not the skull, we would say the scalp. Okay. So the better thing will be the scalp. Okay. So I told you that this is a particular area of the face where you find a modified kind of superficial fascia. Or the superficial fascia is not very well defined. You have something called as a panniculus carnosus. I told you that, right? The face muscles and the scalp, right? So this is something called as a SMAS, superficial musculoaponeurotic system, which is covering in the form of superficial fascia, right? So don't confuse here. It's nothing to worry. Whenever we were talking about the skull is something which is containing pericranium. Okay, that is not a layer of deep fascia. That is something a little different layer. Okay, so Shubham, remember this: ischiorrectal fossa, face. These are the two layers where we don't find deep fascia. Okay, these are the only two places. Right. Now, you're performing a neck dissection, and after dissection of the skin, you encounter this thing. What is this?
So, Binit, I'll come back to you. Before that, Samreen has answered platysma.
Okay.
Vinayak, platysma. Vahini, Soni, platysma.
Okay. So, can anyone tell me that platysma is present in which layer? Okay, superficial fascia. What exactly this superficial layer muscle called as in literal terms? Can anyone name that? So there are muscles in the superficial layer. There is a specific anatomical Latin term. Difficult question, but that has been given. That Latin term. I explained that Latin term also. Can anyone tell me? $1 million question.
Yes, Samreen has answered, sir.
Yes, what is that?
Caniculus caneus.
Not caneus. Carnosus. Okay,
Carnos.
almost correct. Simple. Hey, Latin is the simple to understand if you actually put in these things to. What does carnosus mean? Carnosus means flesh. Paniculus means a sheet. If I talk about the superficial fascia which is containing fat, I call it paniculus adiposus. Okay, and similarly this thing, which is a sheet of flesh that is present. Whoever has answered this particular thing, right? So see this platysma, right? You see these vertical fibers extending from the thorax up till the lower end of the mandible, and it is getting blended with the face. This thing is the platysma, right? Platy means flat sheet of layer of muscle, which is pink in color, light pink in color, and you see it in the superficial fascia. As soon as you cut the skin, you'll get this yellow colored fat of superficial fascia, and then you'll see this layer of shiny muscle. Now, can anyone tell me, if I cut this muscle, what will I see? Think. I've cut the skin. As soon as I cut the skin, I find yellow fat. As soon as I cut the fat, I find this platysma. As soon as I cut the platysma, what will be there beneath it? Anyone? I think answers are coming.
Yes.
Right. Deep fascia. Correct. Absolutely right. And can you tell me what exactly is that layer of deep fascia called as in the neck? I told you it's like a collar. So what is that collar called as? No, not the carotid sheath is separate. That collar is called as investing layer. Okay, remember that. Investing. Yes, Shubham has rightly said. Investing layer. Investing. Okay, just like a collar. So investing layer. Carotid sheath is a modification. Okay, it's a modification of deep fascia which is present, which is containing these vessels. Okay, this is the collar-like fascia that covers over the neck. That is in general called as deep fascia investing layer. Okay, right. Now we move on to the next question. Which modification of deep fascia is present here? So this is something that I told you. Okay, so right. So
Samreen has answered joint capsule.
okay, joint capsule. Now here only we will again revise. So deep fascia, correct, contains the joint capsule. What are the two parts that make the joint capsule? So joint capsule or an articular capsule has two parts. Correct. Vinayak has answered right. Samreen has answered right. Outer fibrous, inner synovial. Correct. Synovial membrane creates synovial fluid. Right. One more thing, except for the synovial as well as the joint capsule, one more thing. Binit has answered right. That is bursa. Correct. And even yeah, one more person has answered. I think I can't see the chat.
Binit, Vinayak, Shubham,
yeah,
Shravani, so many people have answered. So
yeah, I think bursa also everybody has answered. So I'm really happy. Bursas are present here on the sides. Okay. Now in some people, these bursa also get enlarged. That's called as bursitis. Okay. Itis means inflammation. So bursa also can get enlarged and they can cause bursitis. Okay. Extreme knee pain that can cause. Okay. Fine. Right. Now we move on to the last part of our discussion today, as well as my rounds. Which modification of deep fascia is present here? So you have got something which is shadowed. So can you name me this? This is what? So answers are coming.
Yeah.
I think Samreen and Preeti you answered.
Samreen and Preeti
now
answering
Shubham
perineurium.
answered. So it is perineurium. Inside endoneurium, outside perineurium, above that epineurium. Correct? So this is how the 3 layers are. And I told you even Sedon's classification of nerve injuries, how neuropraxia, exonotomesis, as well as neurotomesis happen. Right? So I hope now the students have got some kind of a broader view about the human anatomy. This is how fun it is, right? This is how easy it is if you grasp what you're reading. If you read it through diagrams, I'm definitely telling you, half of your job is done. But somebody's asked something.
Yes, I was about to come back to it, sir. If you're done with it, can I just shoot down a few questions where we have got? Binit Sai has asked, what is the muscle system in face?
Yeah, that is called a superficial musculo-eponeurotic system, SMAS, SAMS. Okay, it's called a SMAS. So together blends with the musculature here. That's why we call it SMAS. Superficial musculo-eponeurotic system. Right. Any other questions? Okay. So this is what my favorite line always is. The best part of your life lies on the other side of your fear. This is said by Will Smith, and it happens to be my favorite line because if you see anatomy, it's all about fear. And if you read anatomy and if you understand it, the best part about anatomy is on the other side of it. Then you start actually getting it. And whoever is, aspiring to be future great doctors, you're not here to become good doctors, you're becoming really, really great doctors, the leaders of tomorrow. You have to master anatomy first. I'm telling you, the concept is gone that we've master only the final year subjects. First year subjects are the whole crux of your knowledge of MBBS. I'm still telling you. And I still go back and read those subjects because many of the memory goes off. But it is the whole strength of your MBBS lies in your first year. How strong and dominating you are. Right? So I think, is there any other question, Aishwarya, from the student side?
No, sir. I think Binit previously also asked the same question. Yeah. I can't find any more questions. So you guys can post any questions if you have right now, while I take 1 minute or maybe less than that to just give away something interesting for our dear students, sir, because see how enthusiastically they are participating.
Yeah.
And they're listening very aggressively that most of them are saying the answers right.
Correct.
And I really like that statement of yours, which you told you like people who actually give a try. Right. And I must appreciate them for that. Okay, so for today, I've got so many people who have answered, and I've chosen some names who has brilliantly performed, and I'll be choosing one name, one person who has topped the list. So we have Samreen today who has topped the list, and I would just like to congratulate her from the whole team of Dr. Polaris. And Samreen, we'll be getting back to you tomorrow with a free 3-month subscription of Dr. Polaris first year contents. I'll definitely come back to you with my team tomorrow. Congratulations on winning that, Samreen. And one thing which I noticed in you is the consistency. It is very important when you are in this field, dear. So be consistent like this. Keep doing it every day so it becomes a part and parcel of your life, because this is what you have chosen as your career. So be like this. And congratulations to others who have been answering very well. Shubham.
I'm very happy. I'm very happy by the student participation, and I really love the fact that they are understanding and then they are answering, and that's what creates better doctors.
Exactly. So I would just like to mention few names like Shubham, Binit, Wahini, Soni, Preeti, Vinayak. You people have been doing really good. Keep trying. We'll come back to you guys with exciting gifts like this. So I think it's time to wind up. So I hope you all enjoyed the session today. And I would just like to see yes or no if possible, so that it will be a real booster for me as well as Sanjit sir, who has been
I really am happy with feedback, because if I'm happy with feedback, then I think everybody's enjoyed it, right?
Yes, they
really
I think
this thing will continue. This thing will continue.
Sure,
we are going to come up with multiple topics and make things easy for you, right?
Great.
How to understand.
So we're happy to see your yes as well. I think it's going to be definitely a booster for our dear Sanjit sir. So we'll come back to you guys on next Monday with yet another topic. And keep tuned, guys, and you'll be getting more interesting sessions like this. Have an amazing weekend, and bye and good night from the whole team of Dr. Polaris.
Good night.